launched at the Kuala Lumpur meeting in July. So I'm going to give you a bit of background about the guideline process for pregnant women and infants, directions of these in-process recommendations, and this time I'm going to focus a bit on the operational and the M&E implications and some research priorities. So as was mentioned by Craig, that back in April of 2012, there was a programmatic update that really responded to new developments, the interest in countries in B+, and it gave guidance to countries about how they may want to move towards B or B+. And this is now updated and more detailed in our current ongoing guidelines. And we saw a bit of this yesterday, that we know that the global plan has a target of reducing infections to 40,000 infants by 2015, and we're this past year at 330, and I believe we're in the 200 range for 2012. But there continue to be some major gaps. ARV access for pregnant women, ART for those who are eligible, ARVs throughout breastfeeding, retention and care across the PMTCT cascade. I will not show a cascade, but the PMTCT cascade is probably worse than those in the regular ART cascade. Early infant diagnosis and determination and final status of the infection in infants. So what have we done in our guidelines? We're following the Treatment 2.0 principles for both pediatrics and pregnant women. Simpler drugs, point-of-care diagnostics, and getting diagnostics to where they're needed to be able to identify and monitor therapy, and community models of care. What were the key issues for children? I'm going to start with children first and then move to pregnant women, because I feel like that will be a better segue into the bottleneck analyses. We know that our ART coverage is quite low. We know our EID, or early infant diagnosis, remains low. Retention of children in care on ART, we don't have all of that information. I don't think I've seen a cascade for children. We know that in infants, we want to have a very effective regimen early on because of high viral loads and rapid disease progression in infants. We know that the mother's ARV for prophylaxis and prevention affects how the child will respond to therapy. And we want harmonization so that there can be good procurement systems. So what we heard yesterday, I'll just emphasize again, our plan in our 2013 guidelines, the directions are to treat all children who are less than 5 years old, regardless of their CD4 count or clinical stage, and to initiate children who are less than 3 years old on a lopinavir-based regimen due to the fact that the mother will have had ARVs during her pregnancy. Otherwise use nevirapine, but we're trying to move away from the initial NNRTI-based regimen for children. So the evolution of the PMTCT guidelines. In 2013, we're moving towards option B and B+, or ARVs for all women. And we heard this before, with a threshold of initiation the same as with adults, of initiating at less than 5 or equal to 500. What were some of the key issues that were discussed in the development of this guidelines for pregnant and breastfeeding women? We kept in mind the benefit and kept high on the priority list, benefit for both the mother's health and prevention of infections. So this is both treatment as treatment's sake for the mother and treatment for preventing transmission, and prevention of partners' infections. There was quite a bit of discussion about, is this prophylaxis or lifelong treatment? And in the end, most people cited on the side that we should be providing lifelong treatment to the pregnant woman. And for B+, we identified that access to CD4 testing and eligibility had become a difficult thing for some of these women, and thus B+, or starting ARVs immediately, was the right way to go. Again, simplifying regimens, harmonizing with adult regimens, using a tenofovir FTC or 3TC and efavirenz-based regimen was considered the way to go in terms of procurement and simplification. And again, viral load access seemed to be quite important for pregnant women as well. And might be prioritized as the person to receive viral load testing early on. Just a note on the terminology. I think there's a couple of changes that will be coming out in these guidelines just to help as it comes your way. We're trying to move away from this idea of triple ARVs, combination ARVs, and prophylactic ARVs. Essentially, it's antiretroviral therapy for pregnant and breastfeeding women, to be very simple and consistent with adult treatment guidelines. We're also trying to move away from the terminology of option B and B+. Although we know that these are highly understood and branded in the field, some people will say, why isn't it A+, or why isn't it something else? So the idea is to speak about lifelong ARVs or ART for the pregnant woman and ART during the PMTCT risk period, or what might be considered B. This would be B+, and this would be B. So we hope that you can work with us as we try to change the branding of this language. And in the end, this is just a simplified version of what you're going to see in the guidelines. Initiate ART for all pregnant or breastfeeding women. And it will be a national decision whether or not to stop after the transmission risk through pregnancy or breastfeeding, or to continue lifelong. And then treat children less than 5 years of age, but prioritize infants, as their risk of death and mortality in the first 2 years are highest. So what are some of the key operational guidance that we've given for both children and pregnant women? We have an entire operational chapter on new models of community testing and task shifting. We've also done work on decentralization and supporting guidance there, as well as for pregnant women, integration of services, and we will have some recommendations on integration of ARVs into the maternal and child programs. So we see a comprehensive ART as part of an integrated service here, and we've talked about this quite a bit. I guess this would be the holistic approach that has been discussed up here on the podium, but that we have HIV testing and antenatal care, we have ARV prophylaxis and treatment done in the maternity, and also more testing for children that can be done at the EPI program to get catch-up or during the breastfeeding period. So what are going to be the implementation issues? And these are going to be highlighted in what we call our programmatic chapter. How do HIV managers at the national level and programs think about implementing these new guidelines? So there'll have to be adequate planning for the change in these guidelines and expansion and integration. So there will have to be a supply chain for the antiretrovirals to avoid stockouts. Task shifting will be key to make this guideline and this recommendation work. There will have to be models of adherence, retention, follow-up, linkages through chronic care, just like with everything we've heard about over the last few days. And assuring access of medicine at peripheral and distant sites. We also believe that there's going to have to be toxicity and efficacy monitoring when hopefully early access to viral load. There will be M&E coming out of the IATT. There's a toolkit that has been developed that gives M&E guidance. And it will be helpful for countries to use that to look at adherence and retention at 6, 12 months and at the end of the PMTCT risk period, and also to really look at the toxicity and adverse events. One thing that came up is because these guidelines were based upon really the feasibility and the simplification of treating pregnant women and breastfeeding women, one very strong piece of recommendations or guidance that will come out of the Pregnant Women chapter is about what are the research gaps. Most of the members of the guideline committee felt that there's still many unknown issues related to starting ARVs in all pregnant women globally. So there needs to be both basic and implementation science research to address some of these evidence gaps and evaluating these recommendations. Some of the key issues are about safety for the ART for all pregnant and breastfeeding women, including birth outcomes, infant exposure during breastfeeding, and resistance. determining final transmission rates in HIV-free survival, and in the context of the functional cure of the infant, do we need to reevaluate our early infant diagnosis algorithm, and WHO will be doing that in the next coming year. And approaches to monitor all of the long-term outcomes, including the cascade. And this is a list of the kinds of questions that the guideline committee came up with, and may be helpful for you as you identify new areas to study in implementation science for TASP. So in the end, very briefly, we'd like to thank the guideline committee, which included Elaine Abrams and Dennis Timberwa, as well as all the folks at WHO who put a lot of time and effort into these guidelines. Thank you.